Morning.
I'm going to stand out a bit once I introduce you and have more people come in because those people will be looking. Hi, welcome. Come on in.
So as they come in, they'll direct them to one of the
Yeah, I'll ask them to go into the other door so they're not coming in yet, so I'll hang out outside for a little bit. So, absolutely. Yeah, it's a nice crowd for early this morning. This is awesome.
Yeah, I had signed up. I know not everybody.
Well, it ebbs and flows, absolutely. So it's all good.
I love the Word app.
I know. So we just have to remind them to do the, they have to go in to do the survey afterwards. So we'll remind them towards the end. So that'll work out really well. All right. Good morning, everybody. Oh my God, that is so pitiful. No one has coffee this morning. Good morning. Good morning. Well, welcome. This is the 20th anniversary of the International Council on Active Aging Conference. I'm very happy to introduce you to Leslie Fuller today. So Leslie's going to be doing a presentation on creating quality culture and environment in dementia care. And she also has a booth at the exhibit hall, so she'll tell you exactly where that is afterwards. And I know you guys are really going to get a lot out of this today. So if you have questions, I know Leslie would be more than happy to answer them. And any other ground rules for you, Leslie, for your presentation?
That's it.
Just take it all in?
Yeah, take it all in, laugh at appropriate times, you know.
Yes, okay, sounds great. Well, welcome.
All right, thank you, everyone. Leslie Fuller, I have been in the field of senior living for 14 years. My passion is helping work with staff and building community within, whether it be assisted living, memory care, hospice, home care, to really help those communities to pass on that knowledge to their staff and build a culture of learning together and proactive thinking. And that's part of what my business, Inspired Senior Care, is all about. So today, I would like to share with you about what are some of the foundations to building quality culture and environment in your dementia care, particularly. I'm going to share 3 key elements to support you in creating strong community culture. And those 3 we're going to touch on: understanding brain change, knowing that our word choice really does matter in our work, and then using positive approaches in building genuine relationships. Now, are there more than 3 keys to creating a positive culture? Absolutely. I have about 18 that I do trainings on and support, but I really felt that these 3 are the foundation of the building blocks for building that understanding and that culture within your community. So the first topic I'm going to look at is understanding brain change. Having a basic understanding of how the brain functions and how it changes when dementia is involved can help care partners to interpret changes that they're observing in the language and in the cognitive abilities of the people that they are helping. When this understanding occurs, it leaves the learner more capable and confident. And don't we want that for our staff members? We want them to feel confident in supporting their residents or patients if it is a home care agency. It leaves the learner capable in implementing new ways of communicating, of preventing and easing stress, and supporting that resident as a true partner. Not being done to, but truly partnering in what their care is. So let's look at 3, what I feel are 3 of the key important parts of the brain and what they control. So first is your frontal lobe. I want everybody to raise your hands. Thank you for helping. Put your fingers on your forehead like this, all right? So right here behind your forehead are your frontal lobes, and they control your higher cognitive functioning. Often referred to, you've heard it referred to as executive functioning. The abilities controlled by the frontal lobes include your ability to plan, your ability to organize, to initiate actions, to self-monitor, and to control actions to achieve your goals. So I would like you to imagine that when dementia begins to affect this area of the brain, the ability to conduct activities required to live independently start becoming more and more difficult. So imagine, if you will, you are working with a resident. Let's say you're in an assisted living community. Your resident voices their desire to be independent. I'm going to dress myself. I don't want anybody in the room. I want to do it on my own. And you oblige that, which you should, right? We're helping them to maintain that independence. But when they come out to breakfast, you see And you see that they have on 3 sweaters, they have on a pair of gloves, and they have on a hat, and they probably seem obviously warm, right? They're uncomfortable. So ask, and I'm gonna ask you all now, of these skills that we have here, where are you seeing a decline in the frontal lobe from that example? I'm sorry? Self-monitoring. Unable to realize that their actions need to be controlled. Anything else? How about organizing? Organizing what they're supposed to put on. So, understanding that these changes are going on to that frontal lobe, what some people might do is just go in, okay, I'll go get you dressed. They can't dress themselves. But that's not the answer, right? So understanding these changes, what support could we provide that would help them maintain that independence but can create a better result? Yes, sir.
Talk with them, ask them an open-ended question on what's happening, what they're doing.
Okay, talk with them. It's the very first thing I have. Yeah, have a conversation with them. What else might you do?
Help them choose clothes.
Help them choose clothes. Being a partner in choosing those items, right? So you're not helping, oh yes.
Create a visual aid.
Such as?
Pictures. This is top bottom shoes.
Okay, a visual aid, perfect. Or maybe with them you help them set up this is an outfit that I know that you really like this outfit. You know, making some suggestions, helping them to determine that piece of it, because that's what they're having the trouble with. They're not having trouble getting dressed. So let's help them with that piece of it and then say, you're gonna look spiffy in that. I'll see you at breakfast. You leave, make sure the closet door's closed. They're not having other visual cues to distract them. They're able to get dressed and leave. Some of you may be saying, that sounds really basic, Leslie, but not all of your staff understand the process that we just went through to think through that, okay? So understanding what that frontal lobe does and how that changes is going to help your staff to maybe think through, oh yeah, that's what they're thinking. How am I going to support them in this? So in this scenario, as we've shifted, we now have encouraged them, we have offered choice, and we've provided independence. And isn't that what you want from a partner? So the second part of the brain that I think it's important to understand are your temporal lobes. Take your hands, point above your ears, all right? This is where your temporal lobes are. They're located above your ears on both sides, and they provide functions including face and object recognition, understanding and expressing language, perception of hearing. Other parts of the brain hear and see and smell, but your temporal lobes are what are going to perceive that and try to process it. And recent memory acquisition. When dementia affects this area of the brain, the ability to understand conversation, to retrieve words, to convey their observations of the words declines. The left temporal lobe, okay, point to your left, this is gonna be important. Your left temporal lobe supports the understanding of language and production of language. This is your language hub right here over your left ear. Your right temporal lobe, this side, has skills in learning and remembering nonverbal information, such as spatial relationships. You know, being able to close your eyes and touch your nose, spatial, it's a part of personal spatial, right? And just understanding the world around you in spatial. If that's damaged, there are a lot of difficulties when it comes to grasping things, to handling things, object recognition and handling. It also is your rhythm side, okay? So it retains rhythm memory, music, poetry, hymns, audio patterns. Memories associated with rhythmic memory tend to stay longer into the dementia journey. Have you ever heard of an individual, maybe you've had examples in your own space, of an individual who's no longer able to carry on a conversation with you, but if you turn on a song that is familiar to them, what do? They sing just like they have their entire life. I get goosebumps thinking about watching those moments, and you have given that person just this moment of recognition, of familiarity, and comfort and success. So If your staff understands that, think about the difference that might make. So listen now to another scenario and think about what we learned about the temporal lobes. So your resident is having difficulty understanding your questions. He points at objects, but is unable to use words to tell you about them. He also appears to become lost in the conversation when multiple people are around. You notice that he is withdrawing from participating in activities. So which skills of the temporal lobe in this example do you see is affected in this resident? I'm sorry?
Perception.
Perception, object recognition, perception. What else? Language. Maybe not understanding the language, getting fewer words out of it, unable to express in language. Is that what you were going to say?
Object recognition.
The object recognition as well? That's right. What side effect do you see taking place for him socially because of these changes? He's withdrawing. He's no longer being as involved. Just imagine for yourself for a second, if you have a hard time understanding what anybody's saying and you want to relate to them and your processing is slowing down and you can't get it out and people's conversation is carrying on and you just throw up your hands, I can't do it. And they begin to withdraw. They need us there to help them back out of that a bit and giving them, using our tools of communication to help make those situations better. So my suggestions in that situation would be to support his reduced understanding of language, we can use fewer words. I tend to talk way too much. My husband would attest to that. But, so sometimes I have to just make myself, if I'm supporting somebody, choose my words wisely. What words? Oh, I added somebody's device. There we go. And somebody mentioned earlier using visual cues to help with them. Because if words aren't working, we have lots of other ways of communication, right? Beyond words. So we need to find those other methods to support them. I have a whole other class on that, on communication. To provide more focus for him in discussions, what if staff were to focus on really having more one-on-ones? Not trying to talk with him or give him instructions when there are other people around. Let's have it private. Let's have it sit down, face to face, eye to eye, fewer words to help him succeed. Because in a crowd, he will not succeed. And then knowing that he enjoys music, he enjoys singing, he always has, so staff find extra opportunities for him to join in musical programs. They always make sure that he's invited to those musical programs because he will likely sing along with that music and he is going to feel more at ease and more welcome and comforting in that session, in that situation. So I hope you can see how basic understanding of functions of the temporal lobes can help members of your team to communicate and support him better. Just even these small steps can make a big difference. And then the third, that I feel is most important brain function to really understand, is the amygdala. So the amygdala is located, okay, you remember where your two temporal lobes were. It's in your pretemporal lobe, so it's right between your two temporal lobes and kind of smack in the middle of the brain is the way I envision it. Its function is involved in processing emotions, including fear. So probably what you've heard, the most common description of it is your fight, flight, or fright response. The amygdala coordinates the processing of the cognitive processing of what's being observed and the physical reaction that's going to happen in response to that cognitive. It's kind of the coach between what your brain's thinking and what your body has the ability to do. Remember, the amygdala continues functioning well into the disease process, okay? So you have these other changes going on that we talked about, but yet that amygdala, it's ready to go. It's gonna respond to what the confused messages are doing. So your cognitive processing takes place in the observation of a situation. This is for all of you. You observe something, your cognitive processing is doing that. Your physical abilities determine what you can do physically in response to those observations. And in a stressful situation, Your amygdala triggers whether you're going to run away from stress, fight it, or just freeze, panic, and fear. Now, remember the frontal lobe? Okay, we're putting all this together. With dementia damage in the frontal lobe, input gets confused, right? And the frontal lobe can send observations that are not accurate. If the amygdala jumps into action in response to that false data, seemingly inappropriate physical reactions may occur. Do you ever have staff talk about a resident and say they were inappropriate? Okay? From their perspective, they absolutely did what made sense. There was nothing inappropriate to it. They were responding to the situation in a very logical way for where their brain is at this time. So, okay, scenario one. I want you, Adrian and I talked about this last night. I want you to all to envision this, all right? Look down at your desk. There's a snake on it. A snake, like a slithering snake. What is your frontal lobe thinking right now? Not your amygdala. What is your frontal lobe assessing about that snake?
I want to determine if it's a venomous or non-venomous snake.
Okay, so we're looking for safety. Your brain's processing, is this safe, is it not safe? What else? Huh? It's not a good thing. There shouldn't be a snake here. Adrian, what would you be doing?
I would be freaking out.
Freaking out. Right. I found out she has a phobia of snakes last night as I was talking about this. All right. So let's think about now what your reaction was. You would get up and you would run. So your cognitive says, this is not good. Your physical legs are going, yeah, what do you want me to do? And the amygdala goes, I want you to get the heck out of here. So it really, in that quick response, it took 3 parts of your brain to work together to make that happen, okay? But let's think about somebody who's living with dementia, and those 3 aren't really working like they used to. So scenario 2, I want you to imagine. A person living with dementia is developing damage to their temporal lobes. She wakes up next to her spouse, but does not recognize them. Now remember, we talked about the temporal lobe is in charge of face recognition. It's misfiring. She does not recognize this person in bed with her. Her frontal lobe responds with, this is a stranger. The safety comes into play. This is a stranger. The amygdala fight response indicates this is dangerous and gives the order to the physical to respond. She then strikes the stranger in the bed. From her perspective, hitting that stranger who was lying next to her was a perfectly reasonable reaction, right? It was not inappropriate. It was absolutely appropriate for what's going on in her mind. So I hope you can see now by having a basic understanding of just these 3, and there are so many other parts of the brain. I mean, I like to just stick with these basics to understand and to help your staff understand that these 3 parts of the brain can help us understand the perspective of the person living with brain change. And with that understanding, we can improve our interactions and increase the quality of care and environment that we're providing. Okay, that was key number 1. Key number 2, we're going to shift over to the impact of word choice. Oops, there we go. How many of you here in this room have, sorry about that. How many of you here have experienced ageism personally? Anybody? Raise your hand high. Be proud of it. We gotta take control of this because it's not right. So we're gonna talk about that. What are some examples that you see in society of ageism? Adrian?
Often people are assumed to be weak or frail, even though there are plenty of very strong, healthy people in their 70s, 80s, and 90s.
An assumption all older people are weak. Yes?
A lot of my residents will not get advised about what exercise is or isn't appropriate for them because doctors just assume that they're sitting and knitting all day. So they have to really advocate to find out, okay, what can I do and when?
Mm-hmm. Yep. Who else? Other examples? So how about magazine headlines? Look younger in 1 week. I mean, the assumption is you need to look younger. Excuse me? And makeup, you know, all the makeup that we see out there, the facelifts, the creams, all of that, you have to look younger, right? In the movies, Having younger actors or actresses play the role of an older individual, that drives me crazy. Why not hire an actor of that age? That actually is ageism right there. Assumptions, I think Adrienne, you already said that, assuming that they're weak or they need everything simplified. They need it easy. I belong to a Facebook page on activity professionals, and sometimes people will put on there, you know, what are some easy activities that we can put on the calendar? You know, that the assumption is that that's how we have to dumb it down. You have to dumb it down. I think that's it, and that is by far not true. Images of older people. When I started my own business, I was like, wow, I need to create this curriculum. I need somebody to help me. So I considered hiring this company to help me with some graphic work. And I said, I need a good picture of someone to represent an older gentleman for something. She sent me a cartoon character of a frail, tiny, hunched over, with a cane, no teeth, horrible hair. And I was mortified, and I thought, number one, I thought, okay, I have job security because people need to be educated, but I realized that that's what people think of as old age. And guess what? Everyone in this room, God willing, we're going to be older. We're part of this. So please fight ageism. It's a very important thing to start becoming aware of, start noticing it. So why are these images and these attitudes perpetuated in our society? What words and phrases do we hear that feed this ageist image? They're condescending. So think about this. Wow, you don't look 65, you look great. The implication is that looking 65 is bad. Hello, young lady, addressing maybe an 80-year-old, obviously not an adolescent. The implication, that word is supposed to be for adolescents, right? Implication is that we shouldn't acknowledge older age, that it is something to be avoided. Wow, sorry, my sweaty fingers, because I'm nervous. I'll be honest here, where to go? Back. There we go, okay. So, hello young lady. That implication is that getting older is to be avoided or to be ignored. Or she's so young at heart. Well, that implication is that older at heart is a bad thing. Seriously? I don't think so. Or raising tone of voice. Have you ever noticed this? I think with younger staff members, I remember years ago, I did it too. I just found myself when I went to support somebody who was older, I raised my voice. It's so good to see you today. Why do we do that? Why do we do that? So I'd like to take this concept a step further and shift to word choice in the realm of dementia care. When we use words such as, she's suffering from dementia, she's trapped, lost in their mind, she was placed in a facility, he's become like a child. The mental image that we portray with these words is an image of hopelessness. The focus is on custodial role for a suffering life. And when thinking in hopeless ways, minds are not led to offering care in hopeful ways. A shift from this kind of institutional language to more person-centered language can positively impact the mindset of both the listener and the speaker. Now, let's think about the difference in your own mindset if instead you heard descriptors such as, she is living with dementia, he is experiencing some brain change, she moved into a community, she might benefit from some additional support, we see some new behavioral responses, let's investigate. Might this shift in word choice cause a shift in attitude and a shift in our approach? If I see someone as a person who is experiencing brain change rather than a person who has lost their mind, might my care for them be better? All right, I have an exercise for you here. I'm going to share with you two narratives telling the same story. As I read each one to you, I ask you to write down some of the terms that really stand out to you, words that may trigger positive or negative feelings for you. Scenario number 1. Mary's father, Bob, is moving into an assisted living, which promotes itself as specializing in dementia care. This setting operates in a more traditional institutional environment. They are focused on symptoms, diagnoses, and medical interventions. I am the director, and I'm welcoming Bob today to our community. Note that this is an exaggerated use of these terms, okay? I crammed them all into one scenario. So this is not exactly normal, but I guarantee you every word that I'm going to use right now, I have heard in my work. So this side of the room is going to be Mary. Listen, this side's gonna be Mary, and this side's going to be Bob, okay? All right. Welcome to our facility, Mary. We are so glad to admit your dad today. Hi, honey. We're so glad to have you today. Hey, Mary, I hear that, is it correct? I think he has some behaviors in the evening. Is that right? Okay, well, they'll look at his med chart and determine how we can help that out, okay? I also see here, has he escaped a few times from your home? Oh my gosh, I'm so glad he's okay. Well, no need to worry because we're a locked unit. He's going to be in room 221 in the back. His room is already stocked with diapers. I made sure to put him on the toileting schedule. Oh, and I think we can fit him in, we can probably fit a shower in on Tuesdays at 1 o'clock, okay? Now, we do allow our dementia residents to go outside for an hour in the morning. If you'd like to come, you're welcome to join him. Mary, we are eager to alleviate the burden that caregiving has been for you. We will take it from here. Susie, can I get you to take room 221 down to the dining room? All right. Share with me. Share with me. What did you hear?
Well, first of all, she was talking to the daughter instead of the resident.
Yep. Oh, we never see that, do we? Oh, talk just to the daughter. What else?
I'm running out the back door.
I'm sorry?
Running out the back door.
A room number. Well, HIPAA. We can't say his name, right? What else? Over here?
He's escaped.
Oh, he's an escapee. Yeah. Oh, that won't happen here because we're locked up. Yeah. Don't. Diapers.
Showering and toileting schedule.
Yeah. But that's when it's going to work best for us, right? Okay. No reference to Bob. Yes, sir.
Oftentimes the presentation doesn't match the experience. So you could have awesome staff and your presenters just horrible. So I don't know what I'd be thinking on that side of the room. On this side of the room, it just depends on what stage of dementia I was in. Because you were talking really fast, I don't even know if I would have understood anything anyway, but you would have been saying a bunch of positive things. So,
And, even if you didn't understand, what was my body language towards Bob? Nil.
And condescending.
It was the only exchange I had was condescending, right? And absolutely, you are right. You can go into any community and you're going to have those who understand it better than others. Sadly, there are some communities that, especially when you have leadership who don't understand this, and that's how they lead, and that's how we as leaders talk. If we talk this way, we feed that and we perpetuate this kind of attitude and this kind of approach.
So a question for you.
Yes, sir.
As you get to know the resident or the patient or however you want to deem it, does your body language and your vernacular change so that to adapt to who they are? And
100%.
How they best respond?
I should pay you. Absolutely. What you said at the very beginning, that get to know your resident. And I use resident, my world has been memory care, assisted living, independent living. I understand in a hospital and in SNFs, sometimes they call them patients and it hurts me because this is where they're living. I don't want to be called a patient. when I'm living anywhere, right? But I do call them resident. But you're absolutely right. You have to get to know that individual and adjust based on what their needs are and what communication level you need with them. The condescending tone, never appropriate. Just never. They're adults. They're not children. They are adults. So very well said. Okay, so now my next scenario.
You have a question?
Yes. Oh, yes.
I kind of have, I'm looking for advice, I suppose. I'm one of those folks that my mission in life is to change words. But even the indication of memory care or dementia care is abrasive to me because I'm not taking care of the dementia, I'm not taking care of the memory, right, of the person. But even going back and forth with, so dementia support makes more sense to me, even though dementia is still first, right, ADA, all that good stuff. But the marketing team is saying, yeah, but people don't recognize your terms. If we're trying to say we take care of people with dementia, you need to use what everybody's used to.
I hear you on that. I get that. In my past company, there was a big decision because they used to call it Alzheimer's care. Well, there are lots more dementias, you know, where people need support. But I think from the public understanding, if you just call yourself a apartment complex, from a marketing perspective, they don't know what kind of apartment you are. And I totally get that. I think that I was an executive director for a memory care community, and we had to have some disclaimer on it. But once they moved in, why do we need to talk about dementia? We need to talk about how to best support the people who live here, and I think that's what you're getting at. So once you are in that environment, I think your word choice as a leader can really affect that, just like you're saying. But it is hard when you're that liaison to the general community and helping to educate what your specialty is for them.
Along that line, where I work, our memory care units are called Garden House. Our marketing people were talking a couple weeks ago about that right there. We're not gonna get people, when they Google dementia, they're not gonna see our garden house. We need to change that. I'm like, really? Because that's what marketing is trying to sell. We're trying to work with and help and support, and you know, and I was like, oh my God, now they get through that, they're not gonna change it. But they were talking about that because it wasn't gonna bring people to their site. It says garden house, it doesn't say dementia care.
Yeah, how do you funnel, and this is Adrienne, my marketing liaison here is going, I could talk for an hour on this, but you know, how do we funnel those people to us? But we're going to give care that isn't focused on disease. So, okay, I'm gonna jump on, otherwise I'm gonna miss some things. All right, so second scenario. Again, this is the same scenario with Mary helping her father Bob, but this location focuses on creating a true home-like setting, where individuals who are living with dementia can live together in a community setting. Again, note that I'm putting all these in one. It would flow a little bit better. There are things that I could say better, but for example's sake, this is what we're gonna do. Okay, all right, Bob and Mary. Welcome to our community, Bob. Is this your daughter, Mary? It's so nice to have both of you today. So Bob, we have your apartment set up. This is apartment number 212, and I have your nameplate here on the door. Mary asked us to stock it for you. We have some Old Spice body wash. I hear you like that smell. Bob, do you prefer showering in the morning? Would you like us to set up to have your shower before breakfasts? Okay, we can do that. I hear you like Westerns and tea. We can set movies up in the evening for you. We can have Westerns. That's Jim. He loves Westerns. I'll introduce you. I welcome both of you to our community. We want to get to know you, Bob, and you as well, Mary. Hopefully you can choose to come in and do some activities and maybe bring some skills that you have to our community. Susie, come here. Susie, this is Bob. Bob, this is Susie. Could you escort him to the dining room and please sit him next to Jim? Okay. What's the difference? Did Bob necessarily understand, to your point, did he necessarily understand everything? We don't know, right? We haven't gotten to know Bob yet. Maybe, maybe not. What else did I do?
It took time before he came to find out his interests and preferences about him and his life story.
So important for activity people to be involved. Usually the activities, I find activities directors, whatever you call them, program managers within your community, it's important for them to, I'm gonna throw this out there right now. Can they go on an assessment with your director of nursing, right? They are in charge of providing so much important parts of their life in that community and educating staff. Why aren't they a part of it? An assessment shouldn't just be about medical. We really need to bring in that kind of thing. Thanks for pointing that out. What's one more thing maybe you noticed?
Just to say, I thought you said, Bob, do you like weapons?
Word choice matters.
Trying to figure that out for a bit, and then all of a sudden the cart went by, and I was focused on the cart.
I need to enunciate better.
That's my reality.
I was hoping you liked Westerns, and there are lots of weapons in Westerns. Maybe I threw that out. But I hope you can see the difference and modeling this for your staff to understand that difference of Bob is a human being, a person. He's someone to get to know. He is not a checklist. And the words that we use impact that so much. I actually created, Adrienne and her team, you don't have to hand them out now, but created a kind of just a quick flyer of the do's and the don'ts, the things to really ask yourself. Go back to your community and listen to how your team speaks and look at some of those words. You know, get rid of this and let's add this into it. So I hope that will help you as you go. All right, let's see here. Okay, I'm gonna skip that because of time. All right, so the third thing that we're going to look at now is talking about approach and relationship. A strong culture, regardless of the setting, regardless of whether it's your work, whether it's your home, whether it's your church, where our residents live, it relies on positive and encouraging interactions among all parties involved. In a dementia care environment, consider these three important positive interactions. First, the importance of a positive physical approach. Second, creating genuine relationships between staff and our residents and their family members. That is key as well. And then third is encouraging and supporting social connections. So I'm going to start. How many of you use TIPA SNO's programs? Anybody? We have quite a few hands. Awesome, awesome. I have a meetup, by the way, if any of you are trainers, consultants, or counselors, trainers, consultants, or coaches, I have a meetup set up for all of us, for any of you, so check that out. TIPA SNO's Positive Physical Approach company, it's called Positive Approach to Care, provides education on effectively approaching a person living with dementia to create a more successful and personal interaction. So what I'm going to do, I'm going to ask for a wonderful volunteer. Joan has already agreed. If you will come up and have a seat here for me. We're going to talk about positive physical reaction, positive physical approaches. So I like to teach with bad approaches, with good bad scenarios. So I'm going to share with you an example of a bad approach, and I witnessed this. I was in a community and observing. It was lunchtime. Staff were absolutely rushed, but I kind of got the feeling this is probably how it went every day. John, would you please fall asleep? Joan's asleep. Joan is in a wheelchair. She's sleeping. I need to go get her for lunch. This is what happened. It literally probably took about that much time too. That is what occurred. What did I do wrong? Everything. Just everything. Now, to your point, do you think this is a caring staff member? No, hold on.
Well, I think it was just a rush.
This young woman, I think, had not worked there long. She was very young. She had not been coached. She had not been trained. In her mind, priority was, I have to get my job done, right? I have to do this well. It doesn't mean that she's not caring. We as leaders just have to teach this. So, TIPA Snow's approach, by the way, I'm a TIPA Snow, what are my technical title? A certified independent trainer for a PAC. So in this process, we need to look at these steps here. First, I need to come from now she was asleep. I'm gonna shift this up just for example, so you can be awake, Joan. Joan is awake. I'm gonna come from about 6 feet away, kind of get her attention. Hey. Okay, what have I done there? What are some things that I did physically?
Touch.
You made eye contact.
I made eye contact.
On her level.
On her level, I smiled. I didn't force it and come up, hey, how you doing? How many times do we see that, right? Hey, how you doing? I just got it. I can see Joan literally as a human being. It's like, whoa, back off, all right? I gauged it and it's like, let me put the invitation out there. She took the invitation. Now I can be welcomed into her world. I got it eye level, whatever their eye level is. Would you like to look like this all day at everyone? Right? It's not welcoming, and this puts us at the same level, okay? I encourage you, I'm not gonna do it now because it's an hour-long class, but hand under hand is a technique that Tiva teaches that's beautiful. Will you stand a second? I'll just do it real quick. When you shake somebody's hand, okay, I'm gonna shake Joan's hand. Watch what I do. So nice to see you. I go to a hand under hand. Who looks in control here?
She does.
She does. Do you feel like I'm controlling you? No. But if I need to support her, if I need to guide her and show her somewhere, hand under hand technique is wonderful. Highly encourage you to pull up some videos and watch. There's a lot more to it that I don't have time to go into right now. But you can see the difference on these physical approaches. Did I miss anything? I didn't go fast either. That was another thing. This girl was just whipping around. And I literally startled you, didn't I? I saw you kind of. How did it feel?
I was imagining what it would feel like if I really was asleep and somebody just grabbed my ankles and started throwing me around.
Right. And what sometimes occurs with that? Let's go back to the amygdala. Bam!
Mm-hmm.
Then guess what you have to do as a director? Fill out that incident report. We've got to send her down to nursing because her nose feels bruised. Uh-oh. How much time? Because staff will tell me, but we don't have time for that. That takes too much time. And then I ask, how long did it take to fill out the incident report? How long did it take to send you to, she has to take a day off because she's got to go to the doctor. Everything. We got to send it into the state report as an ED. Hated those. They were the worst, right? How much time does all that take? But how much extra time does it take for me to just approach her and work with her? It may add an extra minute or so. Okay, that's all right. It's an investment in a good relationship, a better relationship. Thank you, Jeff. All right, so that was the physical. Let's talk about verbal connections. So when we're meeting someone, and I'll go into this here in a little bit, but I call it my 2-minute rule. Try to spend 2 minutes with that person, engaging, being human beings together and working on that relationship before you ever move to a task. So how do we do that? How do we teach staff to engage in ways? Greeting, always welcoming. Hi, I'm Leslie. It's so nice to meet you. And you are? Give them a chance to introduce themselves. Compliments. You always make me feel so good when I come in here. You have such a great smile. Oh, I love that necklace. That is gorgeous, right? Finding ways to connect with them genuinely. Don't make up stuff, but find ways to highlight them and their uniqueness. Share something. I started working here today. Have you been here long? I'm starting to develop that relationship, right? If they can't respond back in words, that's okay. We have to learn, I think that's a hard skill to learn, is how to communicate with someone who doesn't communicate back in words. I still struggle myself sometimes. I have to practice on that and work on that. But we need to acknowledge that for our staff and help them with that. All right. So now we're going to shift to the importance of genuine relationships between staff and residents. To create relationships which support quality care, grow the use of these 3 practices in your community. First, create consistency of care partners rather than rotating staff. This is going to provide the ability to develop an understanding of what the person's baseline is. So a care partner who has developed this kind of understanding and familiarity with them and this intuitive relationship can recognize subtle changes in such things as their routine, their health factors, or maybe mobility. Early detection allows for assessment and adjustment of care. Anxiety can occur when one's sense of security and freedom are challenged. Think about that for us. When we're feeling out of sorts, unfamiliar, I don't know what's going on, do you want to have somebody there with you that's just telling you that it's time to get in the shower? Or do you want to be with someone who is going to be there to identify that and recognize that with you, sit down and share that, and encourage you and say, I'm here with you. We're going to work through this together. So an example of this is Fernando is always pleasant in the mornings. He's a great guy and he welcomes his care partners when they come to help him get ready. However, for the past 3 mornings, the care partner notices that his blankets are tangled in a heap on the bed. He resists waking and he tells her to go away. She recognizes this is not normal and she works with the team to begin assessing him to seek possible solutions. If you have constantly rotating staff, that new staff member just looks, okay, he's grumpy, it's grumpy Fernando, you know, his bed's a mess, now I have to make it. Okay, that's worst case scenario, I get. But that's how that consistency of staff can make such a difference. Second, and some of you already talked about this a little bit, gathering a full understanding of the history and the personality of that individual. So interviewing the resident, interviewing the family members, maybe their friends, learning as much as you can about that individual, not just about their history, but what are their emotional needs? Then be sure to have a system in place to actively share that information with staff. If you know something about that individual, maybe they're an introvert, right? Talk with your staff about what an introvert really is. What does that mean? How can we help support them in that? If your maintenance tech doesn't understand that, and he's a really outgoing guy and he's coming in and trying to high-five Bob and all this, but Bob's like, I just know it's overwhelming. Your maintenance tech needs to know that. So my example involves another amazing maintenance tech. So imagine Hilda's family shared with the community that she was molested as a teenager by a neighbor who was a carpenter. She becomes fearful of men in work clothes or those carrying tools. The maintenance tech is made aware of this situation, of these fears, so he makes sure he only does work in her room if she is not there. And he does the best he can to avoid her if he's carrying his tools. Have we possibly, this wonderful maintenance tech, has he prevented some trauma for her? 100%. Last is, I briefly touched on this, is that 2-minute rule. You know, encourage your staff to attempt to spend 2 minutes with a resident connecting on a relationship level before even completing a task. This 2-minute builds positive interactions and trusts, leads to more successful interactions. Now, you're saying, ooh, 2 minutes, okay, times how many residents, times how many interactions? Can it always be 2 minutes? Absolutely not. But if you teach this and you lead with that mentality, it's going to be in their head, and they're at least, if they get 30 seconds more than they used to have with all their residents, is that better? Is that an improvement? Is that going to help build relationships a little bit better, a little bit at a time? I already talked about that. Pardon me? All right, I got 10 minutes. Our last relationship building recommendation is to support social connections. Research shows that the importance of social connections to mental health for all people. A person living with dementia is no different. An obligation for providing quality care to our clients is to provide opportunities for social engagement, but also encouraging those social opportunities. One of the polls that I put out there, and I hope all of you get a chance to look at it, was what kinds of things do you do to help that new resident who moves in start developing social interactions with people? That's okay. Families and friends often experience guilt or confusion on how to help their loved one who's developed dementia. Their loved one likely doesn't communicate the way they used to, and they feel at a loss as to how to connect with them, and they often pull away. For those living in our communities, support those families by offering training sessions, providing communication skills to them. In the community where I was, we had the InTouch system, the IN2L system, which was amazing. And this grandson came in, and you could tell he was just scared sitting with his grandmother. It was just uncomfortable. They're just sitting on the couch doing nothing. And so I approached and talked with him a little bit. He's like, I don't know, she doesn't talk anymore. And I said, tell you what, come here. So we went over to the IN2L, and I knew which of the programs she enjoyed. And I sat down and I showed him what she enjoyed doing. Showed her, and I got her engaged in it first, and then he picked up on it, and then they developed this ability to have this great relationship in a different way than they used to. We have a lot of work to do, don't we? You all do amazing work and very hard work, but being able to help those individuals who don't know how to communicate, who feel at a loss on this, your ability to help create those social interactions and help them maintain their social interactions is so very important. And last, in addition to social interactions with family, new social connections are important. And I just read an article yesterday about the number of individuals who are moving in communities who have no family or friends at all. They literally are moving in, and you are now their friends and their family. They need to be able to make connections with other people who are living there. So create clubs or common interest groups that are based on information provided from those life histories that we got, that hopefully your program manager was able to go on some assessments with. In my community, we had a lot of nurses and doctors. I created a medical professionals club, pulled them together. They were able to connect and introduce themselves, or I helped introduce, what their specialty was. They just immediately developed kind of this understanding and respect for each other. I brought our director of nursing in so that she could talk with them. She asked for their advice on some situations. They felt needed. They felt a part of the community. Yes, ma'am.
Would having a group like that maybe facilitate a blood pressure clinic if there was, something going on for the staff? Is there a way that you find using their skills that they still retain is beneficial to programming?
Absolutely. In that example, what I might do is say, hey, Mary, I know you're a registered nurse, right? We're having a blood pressure clinic. Would you help us with that and maybe have her help escort people in? Making her still feel a part of that. That's a great example. And you take that example. That's beautiful. I love it. Yeah, I think I had a resident who, let me check time, am I right? I had a resident who was a very strong businessman, and he would come into my office most mornings, and I found something that I needed to pick his brain on. I got a lot of reports to do today, and I have to prioritize these. What would you do? And it was awesome. And it wasn't fake either. If you do things in a fake way, we've kind of lost the whole message here, right? But genuinely being willing to take what they have to say and connect on some level with them. I always hate it when people say, oh, give them this, it'll keep them busy. I understand what happens with the rush of everything we have to do. I understand that mentality, but again, our words, we have to, instead of, this will keep her busy. How about she would really enjoy this? This is something. Just even changing the words that I'm saying about that changes my attitude about how I'm approaching my work and what I do. Whew. All right, so this brings us to a close. So just as a reminder, to go back to your communities and really assess, does your staff have the basic understandings of brain change? Do you? I've spent a lot of time myself literally just going on the internet, finding 5, 6, 7 different websites that talk about the brain, because there's so much going on up there. It's a little hard to understand. And that's why I think taking just those 3 is really helpful to get the basics across to your staff. Next is understanding our word choice matters. The words that you use with your staff, with your families, with your residents, it can change everything. So listen to yourself, listen to your community. Does there need to be change made? And last is our approach and relationships, understanding how those 2 can build to make a difference for our residents, their family, and again, for your staff. Your staff are key. You know, this is their home for 8 hours a day or 12 hours a day. We want your staff to feel confident. I have a colleague who teaches the same way I do, a lot of the same things, and she said after a class she taught, she went back a week or 2 later, and one of the people that she taught said, "Thank you so much." This almost makes me cry, seriously. She said, "Thank you so much for teaching me that. I'm not afraid of my residents anymore." Ooh, I did not expect that to happen, I'm sorry. So really, go back, you do amazing work, and I hope these 3 tips helped you in maybe looking at care a little bit different. So if you would like to, I'm gonna hang out here for a little bit afterwards. If you'd like to talk with me, or information is on my WOVA as to getting a hold of me. I also am in booth number 201 at the expo. I hope you get a chance to stop by and see my curriculum that I created to help teach all of this. And last thing is, any of you that are doing CEUs for this conference, be sure to, and this is gonna be for the whole 2 days, you text that phone number that's up there, and you're gonna put in 102 for this class. And last, I would greatly appreciate your feedback in the methods. How does that work?
So if you're on the app, you're gonna go to surveys, and you're gonna wanna fill out your survey, because you get points for your survey too for the leaderboard.
And your feedback means the world to me in my future work. So thank you so much, everyone. Have a wonderful